So we are here in the ascending colon. So first of all, thanks again, Abed, for having us here. It's a pleasure. You're a great host. Thank you. And I'm here in the room with Shireen, and then Francis and Fazal, which are helping us. And we have this LSTG granular type, which is 2A, I would say, JNet classification.
Yeah.
I'll switch to BLI. We're using a Fujifilm EC760 series and with a working channel of 3.8.
Alberto, let's be honest. If you prefer ESD for this lesion, it's not because you are scared of submucosal invasion. It's because you are scared of recurrence.
Yes.
So you want to minimize the risk for this patient to come back in 2 years with a recurrence that may be at that point invasive.
Yes.
So this is to prevent recurrence.
Absolutely. To prevent recurrence, to give to the pathologist a better specimen, just in case. Although in the right colon, the chances of deep submucosal invasion are
quite
lower.
Yeah.
But yes, and so now after an ESD, the follow-up should be, if it's a zero resection, should be after 1 year. But there is the new evidence which is pushing for 3 years.
Bravo, bravo. This the idea, no? So you are using an under saline, if not you kill me, technique, and you have the new flex knife, 1.5 by Herbe. So can you briefly explain the advantages of this knife and the setting that you are using?
Okay, so the Flex Herbe knife is a great knife, because it provides a better submucosal lifting. Is very efficient with not just with the submucosal cutting, but also with the coagulation, which should be performed with continuous water inflation. And we are using Endocut 1 for cutting, and for coagulation, sweet coag between 1.5 to 2.
Okay, so Alberto, with this new technique that you invented, no, of under saline, can we say that most of the session is done in endocut, and most of the pre-sealing or whatever you call is done with coagulation?
Yes.
So at the end, you are always using the endocut, no, to dissect the mucosa.
The only point is, of course, if I see a vessel, then we'll switch to sweet coag, and we'll have the so-called frozen effect, where we can coagulate a vessel. And I think we probably have here a good example. For example, here we have this vessel. I'm now going to coagulate, and as you can see, the vessel become whitish.
Yeah.
So you provide a very nice coagulation. Yes, please.
So, for the sake of audience here, what is the difference between if I have a polyp in the cecum, right colon or left colon? Which one is there? What are the precautions you take in the right colon or in the cecum?
But from a technical point of view?
I want to your opinion.
Okay, so from a technical point of view, so meaning I'm just talking about ESD strategy, there are no differences. So I'll do exactly the same type of ESD and exactly the same type of step during the procedure. And also nowadays in our hospital, we do the training in all the type of the colon, all the section of the colon.
Yeah,
so we don't start anymore from
Alberto,
the rectum to the colon.
The only difference that comes to my mind is that after EMR, we know that the risk of delayed bleeding is higher for the proximal than for the left. So clipping is recommended for right side. But this may be not the case when you do an ESD as you are doing brilliantly. because actually you are coagulating all the vessel, and this is
Yes.
the difference with the EMR where necessary
Yeah.
you do not coagulate. So probably the real difference may be in the closure approach. We are more cautious with the proximal, no,
Absolutely.
than with the left. Regarding clinical, as Alberto was anticipating, the risk of submucosal invasion, unless there is a nodule, is much lower.
It's much lower,
Yeah.
yes. Although the paper from Jeremy Jacques' group show
Yeah.
that rectum and colon,
Yeah, well, yeah,
that's one paper
Yeah,
against all the rest of the evidence.
yeah,
But, we've done also a multi-center study that we presented at SG Days, and now we will complete the SG Days. Please come
yeah,
all,
come.
and we will represent with all the data about 3,300 ESD.
Wow.
And we show that in terms of deepness of invasion, submucosal invasion, the rectum and the left colon are very similar. The right is still there is a lower risk.
Okay, anyway, I want to clarify that the message from Europe is that ESD for proximal lesion is has become the technique of choice.
Yes.
Anytime there is a nodular component or there is a non-granular type, so it's not anymore an exception. It's becoming quite a frequent
Yes.
examination in our unit. And until a few years ago, this would seem impossible.
Yes. And why is that now?
I feel because the endoscopists feel more confident.
Yes.
The technology is coming behind,
Yes.
and the evidence by Jeremy you can like or dislike about recurrence. Anyway,
Yes.
had its impact
Yes.
on the community, and yeah.
Absolutely. And I think also that nowadays, I mean, 10 years ago we were going to Japan or East Asia to learn ESD, but now the trainers are trained. The trainee are trained in Europe because we have a lot of great center for ESD.
Yeah. And in Europe, colorectal lesions are much more frequent than upper GI lesions.
Yes.
A question that Jeremy and Mathieu would have for you, my dear Alberto, is would you consider traction or the under saline intrinsic traction
Yes.
remove for you the need of any traction? Or now would you like to have a traction toward the...
No, I don't use traction routinely when I do under saline ESD. So I don't need it. Yes, sometimes I use traction when I open the pocket. Maybe that's helpful, but otherwise no. And your meta-analysis?
Alberto, I feel that Edward would be a bit disappointed that you completed the procedure in a CO2.
Yes. So
can you explain how you...
Yes, I completed the procedure in CO2 because I think that ESD is already quite difficult on its own. So you don't want to make your life more difficult, and you don't have to be very strongly dogmatic, right?
Bravo.
So if you can be flexible and exchange whether you might increase the speed of your procedure.
Yeah.
And this is the last cut. And we are basically done, and we, I think, are very happy with the results. Any question from the audience?
I feel that also the timing, Alberto, is important. At the end, it took a little more than 1 hour,
Yes.
probably for what is a 3 centimeter lesion.
Yes.
So I feel this is the time that Japanese
Yes.
use to remove these big lesions. So I feel that the speed of research of European expert like you is now very similar to Japanese.
Yes.
So an ESD is about 1 hour procedure for a lesion that is not nodular, blah, blah, blah. So I feel
Yes.
it is acceptable, no?
Yes,
For the
I
patient.
I think yes, it is acceptable, and as I said, we do it under sedation, and you can do 2 of these procedures in one morning list.
Definitely,
So,
yeah. And then do you dismiss the patient the same day?
Yes.
In the UK, or you
Yes.
keep it admitted?
No, we discharge. So we discharge 68% of our patients. The one we keep are the one who had, large bleeding, or the elderly patient with a lot of comorbidities, or the one that live very far away.
Yeah.
Which in London is sometimes like 2 hours away, But otherwise, we discharged almost
Yeah.
70%.
And I feel that in discharging, the fact that you can close
Yeah.
a defect, is somewhat reassuring because
Yes,
the
but-
risk of bleeding at that point is about 2%, that is extremely low.
Yes, and it's reassuring maybe mostly for us than
Then for the
but
patient.
the other thing is in our center, Cesare, we give antibiotics to all the patient after the procedure. I'm not sure. The guidelines, it's a gray light
Yeah.
because the evidence is very low.
Yeah.
Open, please. I'm not sure what you
I
think.
get that we also give to most of the patients, okay?
Open? Yes.
But we wait during the procedure to see if we did a coagulation in the deep layers,
Close.
or of course if it is in the rectum. So we wait. If the procedure is all superficial, then we may not give antibiotic.
Okay.
But as soon as we have any suspicion, we give antibiotics. So at the end, we give antibiotic in 70-80% of colorectal
Right.
ESD.
And do you 5 days antibiotics, augmentin if there is?
We give augmentin. We used as most endoscopies with ciprofloxacin
Yes.
and metronidazole, but then our anesthesiologist convinced us that augmentin is the real wide spectrum antibiotic.
Yes.
That
We-
give you the certainty, no?
Yes, fully agree. We
Yeah.
do the same. Is there any question from the audience? Open, please. Okay, fine. Mother. Yes, we can hear you very well.
Okay, good. So actually, I saw a clip that you have put on
Yeah.
television. That was like a tiny perforation or something.
Yeah, so we had a massive bleeding on that side, close. So I had a deep muscle injury, fire release. So we place a clip here, this one, and we closed it. And now I'm closing the whole defect.
This is, in my view,
But yes,
Alberto,
maybe you
an
read my mind.
additional advantage of under saline ESD, because even if there is a small perforation, the patient does not experience a pain.
Yes.
What was it you were saying?
So I fully agree. So the patient, we are on sterile. First of all, we are on saline, and it's very, very low flow saline.
Yeah.
And so even with a small perforation, there is no pain,
Yeah.
and the gas doesn't get trapped.
You're right. Yeah.
And the other thing is, I mean, we have to be very clear about and very transparent about perforation. What is a perforation? A 2 millimeter perforation, is it really an issue nowadays? When you see it and you clip it and you give antibiotics, I don't think it's a major adverse
Yeah.
event, for sure.
Yeah.
And most of the time we close it. So these things about perforation, 4%,
Yeah.
5%, etc., I think nowadays we overestimating this.
Yeah, totally agree. If the patient is in well-being, he can be discharged. Only if
fire release.
there is some pain, he can be admitted, because also the fluid go in the peritoneum and may give pain.
Yes.
But as you have seen, Alberto is very smart because he used a tube to continuously aspirate the saline solution that he put. So less saline will go in the peritoneum if ever, and the patient will have less pain. So it's smart also from this side.
Yes, yes. Any other question?
Yeah, Alberto, which type of electrosurgical unit, which mode do you prefer during dissection? Do you go for endocut or?
Yes. So when I'm in my unit, I use a flash knife, and I use Endocatai 114 and Swift Coag 3.5.
And you dissect with endocut?
So I dissect with yeah. So very good question. So if there are no vessels, I dissect with endocut, no problem. If there are vessels, then I dissect with Swift Coag.
Yeah, a message that is important to give, Alberto, is that there is no one universal setting, because the setting depends heavily on the knife. So different knives have different setting. So you don't need to keep one in your mind and to always use that.
Yes.
So
This particular reason, I think it was a little bit vascular.
Yeah.
Using coag, right?
So we had 2 very severe arterial bleeding, and I wasn't able to stop it with a knife. And guys, there is, I mean, it's not a sign to take out the co-grasper and use it
Yeah.
if needed. Another thing, though, if you are close to the muscle layer, is to use a Purostat.
Yeah.
3D matrix, because with Purostat you can put it on the bleeding point, you can then make some compression with the tip of the scope, wait there for a couple of minutes, and it will be very effective to prevent any bleeding. And close to the muscle, you using the co-grasper, you increase the chances of post-polypectomic syndrome or delayed perforation. So that's another good trick.
Okay, we have a very last question because we have to conclude now. It's okay for the trick and I'm very considering. The question is, in your practice, do you do the first ESD for lesion or you reject ESD for high-risk lesion?
Sorry, say it again, I didn't get it.
If you do for high risk lesion or for any lesion in the proximal colon.
So, in my practice at the Royal Free, we do only unblock resections, only ESD. We don't do piecemeal EMR. But
No, no.
By Michael Torv, where he said the number needed to treat the right lesion, if you have one lesion that is cancerous,
yes,
by ESD is 142.
Yeah, but remember that now we do for recurrence. We don't do anymore for submucosal cancer. This is where Jeremy Jacques push ESD out. And this is also somewhat the idea of Japanese. You have no recurrence, you have better histology examination. So the number needed to treat to detect one cancer, that I totally agree with you, no? Is not anymore the only outcome of ESD in the proximal colon.
yes, and I just want to add another thing, that Michael Berg's paper, I mean, Michael Berg says, of course, our respects, he's a great endoscopist, he's a great researcher, and he provides a lot of evidence to the endoscopic guidelines and evidence in general. But his work, differently from Jeremy Jacques' work, were based on piecemeal EMR. So I think this is an initial bias.
Yeah. Yeah, definitely.
Well, thank you so much. This was a great session, marvelous session, amazing cases, amazing staff, well illustrated, and I thank all the audience. Next, we're going to move to lectures. Thank you.
Thank you. Well done. Grazie Cesare.
Sei un grande.
Siamo... No, open. Yeah, give me a bigger one.
Sì,
Grazie mille
do you
per
have, do you have the Boston resolution? Di Boston.
No, I'll get the 16.
Ok, 16 of,
Ci vediamo dopo?
No, sto qua. Mi tolgo solo...
Ma se vuoi andare, c'è.
No, mi tolgo solo il camice.
Okay. Okay, sorry.